At the beginning of 2021, there were some pretty significant changes to evaluation and management outpatient coding. We're using brand new scorecards, and there's some big updates in the CPT book. So let me help you out, and we're going to go over some cases today and score them out based off of the 2021 evaluation and management guidelines. Hey there, welcome to my channel. I'm Victoria Mull. I'm a medical coder, auditor, educator, content creator, and Jim Henson enthusiast. And on my channel, I provide tips, tricks, and tutorials to help you be successful in a medical coding career. Because there were some significant changes to the office and outpatient visit codes for 2021, I've gotten a lot of requests to do some basically just case scoring, just go through a handful of cases. And I'm more than happy to do that. You know, we used to do them on my little grids that I got from Novitas, and now we actually have a brand new grid that I'm going to be using. If you have your 2021 CPT book, there isn't really a good page with the grid in it, but you can find the information in your CPT book on, I believe, page 16 and 17 in 2021. It will not be in the 2020 edition at all. Actually, let's take a look at the CPT book right now. I can show you where it is. If you look at where the codes are in the CPT book, you can see them here. But then also, if you flip the page back, it's where essentially the grid is. It's pretty much the same information as what is on the AMA grid that they provide, but since it doesn't really fit, I mean, unless they put it sideways into a book, it's kind of broken down into a couple of different sections in the actual CPT book. So you can find it here on page 16 and 17, all the instructions on how you score out codes 99202 through 99215. Now, I recommend that if you are going to score out a lot of E&Ms, that you come up with a good score tool. There are some that have been made available. NAMUS, the National Association of Medical Auditors, has one. AAPC has one. It's still a little bit outdated, not that you can't score correctly with it, but they still have the 99417 listed as 99XXX. I think it is a download, though. I'll try and hunt it down, and if I can find it, I'll include it in the description. Now, another thing to keep in mind is that although we've changed E&M guidelines, your Medicare contractors might have some specifics that they do or do not accept. So depending on where you are in the country or where you're coding for in the country based on the place of service, they may have different guidelines about what they count as far as certain components for medical decision making. In Novitas, they've always taken things like prescription drug management as even refilling a medication, and I kind of tried to dabble around some of the different contractors and see what they do and do not take. And I know I looked at WPS, and it looks like Noridian, and a lot of them do take prescription drug management now to be any kind of management of the drug. So when you're coding, just be careful, because the place of service of where the encounter occurred could be impacted based off of the different jurisdictions and their interpretations of the policy. What I did is I checked like WPS and their website. They have a search box. A lot of them do have search boxes you can use and type in their evaluation and management and find some of their information. I was actually able to find a WPS training that was on YouTube. I can link it for you guys here and here. And one of the things they said, for example, for prescription drug management, is that it doesn't include over-the-counter medication, and it doesn't include prescription strength doses of over-the-counter medication. But they did say, as far as prescription drug management, is they define it as you have documented your evaluation of the patient condition and determined the course of prescription medication for that patient. So that really doesn't specify refills. It doesn't specify if you decided to decline, but I would say if the documentation has anything in there where you can say they determined the course of prescription medication and that's in the documentation, we could count it. One hack that I found helpful when I'm coding for evaluation and management to kind of try and speed things up is just based off of the bell curve. The majority of cases in E&Ms are going to be either level 3s or 4s. I found personally when I code, a lot of them are level 4s. So I start with the mindset that I'm going to code this as a level 4, and I look for the level 4 criteria. If I can meet at least a level 4, then I'll check, is there anything in here that I could maybe bump it up one level and go to a 5? If not, then it stays at a 4. If I look for a 4 and I don't find it, then I go down and look at our 3 criteria and go, okay, maybe there's something I can do to make it a 3, because that's where the majority of the cases are going to lie, in that 3-4 range. Let's get into this first case. A reason for visit, 6-month follow-up visit for coronary artery disease. 67-year-old male who suffers from chronic anxiety and COPD and DJD, has been having a lot of pain in his back and pain in his left knee. He has also been having trouble getting his nerves under control. He is having stomach pain and occasional nausea. His teeth are bad and need to be pulled. He has had some chest pain, but overall does not sound too concerning. He does note some more shortness of breath than usual. He's had no palpitations or lightheadedness, no problems with edema. Now keep in mind, as we're going through these, even though we're coding now based off of medical decision making, we still want to make sure that we're not missing anything in the HPI or the exam. So we still want to read the note and score it out in its entirety. We have our medications, we have the review systems, otherwise unremarkable. Exam, we have blood pressure, no JVD, carotid bruits, cardiac regular rate and rhythm, distant heart sounds with a 1/6 murmur at the upper sternal border. Lungs are clear, abdomen mildly tender throughout the epigastrum, extremities no edema. Oh, they have an EKG here. They reviewed an EKG. Echocardiogram, normal systolic and diastolic function, moderate possible gallstones. Impression, we have CAD. He has a stent. Dyspnea seems to be due to weight and the disability from his knee. His echocardiogram shows no systolic or diastolic function. I like that this is here because this definitely shows us that he did in fact look at that EKG and not that he just pulled that information in from the EKG and didn't actually review it, because he's saying here he actually looked at that EKG. Patient has knee pain. They're going to refer him to orthopedics then they're going to refill his prescription. Dyslipidemia, numbers today are good. Triglycerides, LDL. He gave some samples of Lipitor, panic attacks, and anxiety. Oh, he's on Xanax. See what I'm talking about? That's our prescription drug management right away. I'm looking at this right now and seeing he has Xanax, he has dyslipidemia, he has coronary artery disease. Like, these are chronic conditions, and that right away is I'm looking at this and thinking it's a level 4. Panic attacks and anxiety. He's on Xanax. Abdominal pain, asked to restart his this is GERD medication, omeprazole, and I am going to reduce his aspirin. And prevention, I do not think he needs to be on Plavix. So right away, I'm thinking this is probably going to be a level 4 unless I can't meet one of the columns, and then it might be a level 3, but it's definitely not going to be something that I think is a level 5 visit. I'm not seeing any kind of imminent problems with the patient that need to be addressed or a ton of data that was reviewed. So right away, I'm thinking prescription drug management, and over here I know there's some chronic diseases, two or more stable chronic diseases. Let's go back to the note. How many chronic diseases did we have? We had coronary artery disease, that's a chronic condition. We had dyslipidemia. We had panic attacks and anxiety. I would say those are probably chronic conditions. For argument's sake, they're on medication for them. They've been on Xanax. Although they're not giving refills. So that might be a little bit indicating that maybe it's not completely chronic. They're not giving refills. We'll see. But definitely we have at least the coronary artery disease and the dyslipidemia, because they're even checking on it. They're checking on it. So those are chronic conditions. So I would say right away we're already at a level 4. I'm not seeing anything on here that would really indicate to me that it would be a level 5. There's no severe exacerbations. There's no threat to bodily function or life. We didn't do a ton of data reviewed. We didn't do major surgery, monitoring for toxicity, but just for the sake of also scoring that out, we did review that EKG. So I do want to make sure that I show you guys that we are going to look and mark the EKG on here as well. So we have the echocardiogram, we have the electrocardiogram, we have some labs here that he reviewed. It looks like his lipid panel, I'm going to assume this is, which would count as 3 bullets here under our category 1. And we only need one of these 3 categories, so that we could count as a moderate amount of complexity of data reviewed as well. And this looks like an established patient, so it would be a 99214 for established. Now, one of the things I also like to do when I'm coding E&Ms is go and see what diagnoses are we treating this patient for and kind of get a mental thought of what I think it might be. So for this case here, this patient is being seen for foot pain. So I might not even think right away, this is probably not going to be a level 4. I'm probably going to look for more just based off of that severity, like a 3 or a 2. But you never know. They could have ordered a lot of labs and x-rays or something because maybe they have chronic conditions that they didn't list here, but we'll see what's going on. 32-year-old female comes in again after not having a primary care physician. She was at Dr. XYZ's office today for her appointment, and they canceled her appointment because she has not gotten her Project Access insurance into effect. She says that Project Access is trying to find her a doctor. She's not currently on Project Access, so she's trying to find something here for her foot pain in her foot. I did notice that she went in to see Dr. XYZ for a primary care physician visit on the May 14th. She said she does not have a PCP. She was just in here last week and saw Dr. XYZ for back pain and was put on medications and muscle relaxers. She's been in here multiple times for different kinds of pain. The pain she's having is in her foot. She had surgery on it. She says she has plates and screws. She was supposed to go see Dr. XYZ about getting some hardware out of it. The appointment was canceled. That's why she came in here. She started hurting a lot yesterday, but she had this previous appointment with Dr. XYZ, so she thought she would just take care of it here, but they would not see her. She did not injure her foot in any way recently. It's chronically painful. Every time she does exercise it hurts more. We have x-rayed it in the past, so that doesn't say that they reviewed or ordered any current x-rays. She has some hardware there. It does not appear to be grossly abnormal or causing any loosening or problems on x-ray. Evaluation of her foot shows some well-healed surgical scars. Top of her foot, it looks like she has some lateral aspects below her ankle. She has a long scar. They're all old. Surgery was done over a year ago. She was walking with a very slight limp. There's no redness, no swelling, mildly tender around the foot. It is not warm or red. She's here for foot pain. She's been here before. She seems very pleasant. Thought she certainly might be having some significant pain. So I gave her, here's a prescription drug, gave her some Lortab to take with a refill. After she left, I got to thinking about it and looked into her record. She's been here multiple times for pain medicine. She's a primary care physician, is now telling us that she does not have a primary care physician. Oh my goodness, oh gosh. Even though she has seen Dr. XYZ not too long ago, we called Dr. XYZ's office, and the nurse said that the patient did not have an appointment today. She has an appointment on June 15th for post-op check. They did not tell her that they would not see her today because of the insurance, so the patient was lying to me. Oh my God. I'm sorry. We will keep that in mind next time she returns because she will likely be back. She did say that Project Access will be approving her insurance next week, so she'll be able to see Dr. XYZ soon. So right away, we have at least our prescription drug management. I don't know that we have 2 chronic illnesses. There's nothing systemic about the foot pain. It's not complicated. I would say more it's the one acute uncomplicated illness or injury. It doesn't to me sound like 2 or more chronic illnesses are going on here. I don't think there's anything I can do to bump it up to a moderate level of number of complexity of problems addressed. I'm not really seeing a lot of review of old records. I'm not seeing a lot of data that was reviewed, a lot of just the patient talking about what her issues are going on. It looks like the record review wasn't necessarily about specific labs or notes that they were looking at, just that, she had appointments elsewhere. So because we don't have much else going on, I think this is going to bump us to a 3, and we can at least meet this criteria here. So because we have 2 of the 3 of these columns, we can hit the level 3. Even though we got the higher one here, we don't have any other things in this column or this column to meet the level 4. So we're going to code this one, I think, a level 3. Now this one here is another one. I'm looking at this diagnosis and going probably not a 4. I'm thinking this is a 3 or a 2 just based off the fact that I'm seeing wasp sting here and not any other chronic conditions that were managed. So that's my mindset right now. I'm thinking this is probably a 2 or a 3 because it's a minor problem. Patient is 29-year-old white male with a patient of Dr. XYZ and comes in today complaining that he was stung by a yellow jacket and now has a lot of swelling in his right hand and right arm. He says that he has been stung by wasps before and had similar reactions. He said that he wanted to catch it early because he has too bad of a severe reaction in the past, And he has a lot of swelling, no anaphylaxis type reactions in the past, no shortness of breath, no difficulty, no closing of the throat, no racing heartbeat, no anxiety, just a lot of localized swelling where the sting occurs. We have our exam here, vitals, extremities. Of course, there's swelling in the extremity, medial side with significant swelling, his hand, the right forearm, extending up to the elbow. He says it's not really painful or anything like that. It is not really all that red, no signs of infection. And again, we've just got this one diagnosis. It's an acute, uncomplicated illness or injury. We are giving some prescription drugs here. We've got this Solumedrol, which is prescription. Benadryl is over the counter. And okay, so we've got here, let me go back and I'll actually erase all of my little markings here. So we've got our wasp sting, which is an acute uncomplicated illness or injury. We've got prescription drug management. We don't have 2 or more chronic illnesses that we're treating. We don't have 1 chronic illness with an exacerbation. We don't have any systemic symptoms, so it hasn't spread to any other systems. So there's nothing going on with his lungs or kidneys or anything like that. It didn't spread anywhere else. It's not really a complicated injury. So in that case, you know, we can't, again, we've got 1 in this row, but we don't have anything else to meet that level 4 criteria. But, you know, we still have at least 1 acute uncomplicated illness or injury, and we have at least a low risk, so we can still meet the criteria for a level 3 visit. Now you may be wondering why I did not count that as a self-limited or minor problem and code it as a level 2. Well, the definition of self-limited or minor is something that if the patient hadn't received medical services that day, it would have kind of resolved on its own. And in this case, because the patient did need some intervention, some prescription drug management, I think we can at least warrant it to be an acute illness or injury versus just something self-limited or minor where maybe the provider would have just told them to put on a warm compress or something. Here we have a case, 23-year-old white female presents with complaints of allergies. She used to have allergies when she lived in Seattle, but she thinks they are worse here. In the past, she has tried Claritin and Zyrtex, both worked for a short time and then seemed to kind of lose effectiveness. She has used Allegra also. She used that last summer and she began using it again 2 weeks ago. It does not appear to be working very well. She used over-the-counter sprays, but no prescription nasal sprays. She does have asthma. So there's a chronic condition right there. Let's see if they dropped it in, but does not require daily medication for this and does not think it's flaring up. Medications, her only medication is her orthotricycline and Allegra. She has no known medicine allergies. We did a little bit of an exam here. We're noting that she has some erythema. She's got nasal mucosa is a little bit swollen, clear drainage, tympanic membranes were clear. Supple without an adenopathy, lungs are clear. Assessment, we're diagnosis here with allergic rhinitis. Again, we're probably thinking more that level 3 range, but let's see. She will try Zyrtex instead of Allegra. Now be very careful because if you're not familiar with these medications, you might think, oh, these are prescription, but these are available over the counter. So even if they're giving them something that they're giving them a script for, they still have to be something that they can't get without a prescription. So even if they're giving them a script for Zyrtec or giving them a script for a very high dose of ibuprofen, they can technically get those over the counter. So anything that is available for the patient to purchase over the counter still counts under over the counter medication and not prescription medication. It's not the prescription script itself that designates if it's a prescription. It's can they go to the pharmacy and pick this up without a prescription. But let's take a look because maybe they refilled an asthma medication or something that she's on. Maybe they're going to throw in another chronic condition at the assessment and plan. Who knows? But these are over-the-counter medications. If you're not familiar, if you see a medication and you're like, I don't know what this is, Google it and see if it's something that you can purchase over the counter or if it is a prescription drug that you have to have a prescription for. There's some great websites that you can find just by Googling around and figuring things out. So another option would be to use loratadine. She does not think she has a prescription coverage, so that might be cheaper. Okay, so yeah. Samples of Nasonex, 2 sprays in each nostril, given for 3 weeks. A prescription was written as well. All right, the Nasonex I'm not entirely certain about, so I just Googled it, and it looks like Nasonex, from what I can see, is not available over the counter, and they did give a prescription. Flonase, it says, is available over the counter. Nasonex is not. So in that case, we will count for prescription drug management because we can see on here that the patient did have a prescription strength, prescription only medication that was provided. So here we have the Nasonex. So we're going to count for our prescription drug management. So there's our prescription drug management. Now the problem we're going to run into is this is another one where we just really have one acute condition. We don't have 2 or more chronic illnesses. There wasn't anything really complicated going on with this. Now, if this patient had 2 chronic conditions that the provider also managed during this encounter, they had like hyperlipidemia and hypertension, we could have counted that as the 2 chronic illnesses and made it a level 4. But in this case, we don't have anything else because they're not, for this kind of condition, going to review a lot of data or labs or anything, or they're not going to order a lot. There's nothing here in our number of complexity of problems. So again, this is going to be another one that's a level 3 because we can justify, all of these because we're up to this level. So we're going to hit the level 3. We're not going to make it though to a level 4. Patient is a 78-year-old female with problems of essential hypertension. She has symptoms that suggested intracranial pathology, but so far workup has been negative. She's taking hydrochlorothiazide, 25 milligrams once a day, and K-Dur once a day with adequate control of her blood pressure. She denies any chest pain, shortness of breath, PDN, ankle swelling, and dizziness. Heart rate is 80 and blood pressure is 130/70. Head and neck are unremarkable. Heart sounds are normal. Abdomen is benign. Extremities are without edema. Patient reports she had an echocardiogram, so that's not review of one, done in the office of Dr. K, and was told that she had a massive heart attack in the past. I have not had the opportunity to review any of that data, like a chest x-ray, echocardiogram, EKG, etc. I placed in an order for her to have a chest x-ray and an EKG done before her next appointment, and we will try to get a hold of the echocardiogram from her, but that doesn't say that they do have it and they reviewed it. In the meantime, she's doing quite well, and she is advised to continue her current medication and return to the office in 3 months for follow-up. So we ordered 2 tests, which means we can hit our category 1 here. We're going to assume this patient's being treated for hypertension, so we've got 1 stable chronic illness. I don't know that we even saw, did we see a prescription drug in here? I don't know that I even saw a prescription drug in here. It says what she's taking. I don't see really a lot of management of it. So in this case, I think we're looking at more of a level 3. They're not saying yet she has any intracranial issues. It's just really the hypertension. I mean, thankfully he didn't say history of hypertension, so at least we've got that. But there, I would say we've got the 1 stable chronic illness. We did order 2 tests. It's the 99213 because we've got 2 of the 3 items in this row that we need in order to score it to a level 3. I hope that was helpful to kind of go through my mindset of how I kind of piece together E&M services and start with almost that mindset of let's see if I can reach a level 4, and if I can reach the level 4, maybe it could be a 5. If not, I don't need to look lower because it's a level 4. Or if I don't hit that level 4 criteria, start seeing, is it the level 3 criteria? Is it the level 2 criteria? If you found this video helpful, make sure you give it a big thumbs up. Don't forget to subscribe and hit that notification bell so you can get alerts when I post new episodes. I will see you in the next episode, and until then, just keep on coding on.